You know that feeling when everything just clicks? Your mind is sharp, your mood is steady, your body feels like it's firing on all cylinders. That's not luck, that's what your body is capable of every single day. Now, I've looked into a lot of fish oil supplements, and honestly, most of them are mystery sourced, overprocessed, blasted with heat, and packed with synthetic add-ins. But this one is different. Omega-3 Rejuvenate from Big Bold Health starts with wild Alaskan salmon and cod, sustainably caught from some of the cleanest waters on the planet, and then it's processed at low temperatures to preserve what actually matters. We're talking about real omega-3s, naturally occurring vitamins A and D, and pro-resolving mediators, or PRMs, that help your body balance its own immune response. What does that mean for you? Clearer thinking, more stable mood, and real nature-based support for your heart and immune system. No shortcuts, no synthetic nonsense. And it was developed by Dr. Jeffrey Bland, a true pioneer in the world of complementary health. If you want to feel the difference, go to bigboldhealth.com/Hoffman. That's bigboldhealth.com/Hoffman and use code Hoffman for 20% off site-wide. Once you feel it, you'll know. Welcome to today's Intelligent Medicine Podcast. I'm your host, Dr. Ronald Hoffman. It is no secret that Americans have lost trust in our healthcare system. There's been a steep decline in confidence in health authorities and in doctors in general. Today's guest is Dr. Aaron Kheriaty. He's author of Making the Cut: How to Heal Modern Medicine. And his contention is that there is indeed a cure for medicine's ills, but it's going to hurt. Making the cut, kind of the metaphor. It's about what's going on in medicine, how medicine got sick, and potentially what is the cure. Dr. Aaron Kheriaty is one of the country's leading public intellectuals and a preeminent bioethicist. His training is in psychiatry, but he is now teaching bioethics. And he has written this excellent book, which is entitled Making the Cut: How to Heal Modern Medicine. And I have to say that in reading the book, it kind of took me back to my days during my medical training, during that arduous hazing process, which was my internship and residency. A lot of the anecdotes in the book really paralleled my experience in my training. So welcome to the program. Thanks very much for joining us.
Thanks. It's great to be with you, Dr. Hoffman.
Indeed. Well, tell us, you describe yourself, and I can also resonate with this, as kind of a reluctant medical student. You didn't really, have a lifelong ambition to go into medicine. You kind of decided, well, I want to go into medicine. I want to help people. And you entered it kind of like an anthropologist, with a pith helmet, studying an alien civilization. So tell us about that.
That's right. I think I've never lost the sense that I was both an insider as a physician and an outsider as a kind of unconventional physician. And I think that did begin with my medical training. I had a strong interest both in science and the humanities. And my then fiancée, now wife, advised, well, if you go and you study, let's say, philosophy and do academic philosophy, you'll be focused only on that topic. Whereas if you do medicine, you can expand into things like bioethics and potentially do both. And that was good advice. So I went to medical school, but I wasn't a part of the gung-ho pre-med crowd. I think I didn't know entirely what to expect when I got to medical school. And Making the Cut, in part, is a memoir of medical training. And that aspect of the book is meant to basically tell the story of, first of all, my patients, who were some truly extraordinary people facing extraordinary challenges, but also tell the story of basically how I fell in love with medicine, somewhat to my surprise, which sounds kind of weird. Why would you go to medical school if you weren't in love with the profession?
But it's a little bit of a love-hate relationship. Which,
that's right. It's a complicated
I share
relationship.
That perspective. Yeah.
Yeah. So the book is also a criticism of contemporary healthcare. And given my underlying philosophy of medicine, which I try to articulate in the book, that's the starting point for a pretty stringent critique of contemporary healthcare and contemporary medicine and the ways in which things have gone wrong. But it's always, the critique, I hope, is always from someone who loves medicine dearly, right? And that's what makes it so painful when you've seen something done well. When it's not done well, it becomes all the more sort of acutely difficult. And so rather than just a critic shaking my fist angrily at a broken system, I want to say, look, I fell in love with medicine. Medicine is beautiful, but I'm really sad because my lover has turned prostitute of late.
Okay.
And that's painful. And here's what I propose to try to help medicine recover its original vision. And if we can do that, I think that's the only thing that will address the problem that you mentioned in your introduction of the decline in trust in physicians and healthcare institutions and modern medicine in general. How do we address that? It's not going to be a new slick marketing campaign on the part of the local hospital system. It's not going to be done through window dressing, around the edges of customer service for patients. It's going to require some pretty fundamental changes in reorienting medicine in fairly radical ways. But I think that is ultimately the only way to regain the public's trust. I think there's an appetite for that. I think there's a lot of physicians like you and I who are not entirely happy with the current system, right? We want to find alternatives. We want to create a sort of parallel, what I call in the book, a parallel polis, a parallel set of medical institutions that opt out of some of the strictures and some of the sort of systemic problems in contemporary healthcare. So there are early examples now, I think, experiments in delivering care, financing care, providing medical services in novel ways. Some of those experiments will prove successful and work. Others will not, and they'll be discarded over time. But I think we're at this kind of inflection point where that's what needs to happen. Trying, as I argue in the closing chapters of the book, if my diagnosis is correct about contemporary healthcare, the problems are so systemic and endemic. They're so deeply rooted, and there's so many financial interests that are benefiting from the continuation of the status quo that I think it's hard to really reform the system from within. So some effort to opt out of the system, to use what still works within the system whenever you can, but for much of what we're doing to in fact try things that are entirely new. It seems to me we're at an inflection point where that's what needs to happen. And there's a supply issue because there's doctors that want to provide that, and there's a demand issue because there's many patients who are dissatisfied with the system. And if we can join those two things together, right, the desire to provide healthcare in a different way on the part of physicians and other healthcare practitioners, and the desire of patients to find physicians who are willing to practice medicine differently, then I'm cautiously optimistic that we can actually develop things that move us in the right direction.
Well, you've also been an outstanding champion of health freedom. In fact, prior to writing Making the Cut, you wrote a book entitled The New Abnormal, The Rise of the Biomedical Security State. And you have also been a participant in a lawsuit against the government about censorship. It's the very celebrated Missouri versus Biden case, which ultimately resulted in a decision against the government.
Correct.
For some of the censorship that they undertook during COVID. So tell us a little bit about the history of that case and what's the status of it.
So that case started back in, 2022, a few months after I had a run-in with my employer, the University of California. So for 16 years, I was a professor in the School of Medicine at the University of California, Irvine, where I also directed their medical ethics program. And I was on a committee at the University of California overseeing all 5 of the hospitals in the UC system during COVID. And we developed all the COVID policies up until the vaccine mandate policy, which came down from on high. Our committee was not consulted. I was concerned and confused about that because I knew of all the policies that we had developed during COVID, this one was going to be the most publicly and the most ethically controversial. So why wasn't it being vetted according to the usual process? To try to get a conversation going, because I was getting stonewalled on that committee and at the office of the president, I published a piece in the Wall Street Journal arguing that university vaccine mandates were unethical because they violated the principle of informed consent, that principle that's so dear to health freedom advocates. And that was a bulwark of 20th century medical ethics going all the way back to the Nuremberg Code following the Nazi atrocities of World War II, the things that the world put in place to try to prevent the kinds of abuses that Nazi doctors were engaged in. And it struck me as exceptionally reckless that we were simply tossing that principle overboard out of fear or under this supposed state of emergency during COVID. So I published this piece. The university finalized their vaccine mandate anyways. And then I was publicly opposed to it at that point. So I had all kinds of people reaching out to me at the university saying, I'm going to lose my scholarship. I'm going to get kicked out. I had nurses that I had worked with every day during the pandemic reaching out and saying I'm going to get fired after decades of service in the hospital because I'm going to choose to decline this novel product that I don't think I need. So I made the fateful decision to file a lawsuit in federal court to try to challenge the university's vaccine mandate. And I like to tell people, if you want to go sideways with your employer really quickly, a very efficient way to do that is to sue them in federal court. So even before that case was decided, the university wasted no time in firing me, essentially.
Right. You actually had some illustrious co-conspirators in that, some people who have actually been relatively vindicated in terms of their professional careers.
Yeah, that's right. Yeah, so Joe Ladapo wrote a nice declaration supporting me in that case. He's
Surgeon General of the state of Florida.
Of Florida, that's right. And several other faculty members at the University of California.
Was Jay Bhattacharya involved at that time?
No, but he was involved in the other case that that you mentioned, the Missouri v. Biden case. So sorry, long-winded preface to that. So my involvement in the free speech case with Jay Bhattacharya, with Martin Kulldorff, who's also now working for the Department of Health and Human Services, happened shortly after I got fired. I got a call from John Sauer, and some of our listeners may actually know that name. At the time, John Sauer was Solicitor General of Missouri. That's like the lead litigator in the Attorney General's office. And the reason some folks might know that name, especially if they're lawyers, is that John Sauer is now Solicitor General for the United States. So he's a very prominent attorney, and he was concerned that the federal government was leaning on social media companies to censor people. That we knew during COVID there was a lot of censorship on YouTube and Twitter and Facebook and so forth. But what most people didn't realize was this was not just the private platforms that were taking down your content if you were arguing for principles of medical freedom or criticizing the government's COVID policies or whatever. It was actually the federal government, the White House, several of our public health agencies, even the FBI and the State Department, pressuring social media companies to do their bidding. And while people can argue about whether private entities should be able to censor in that way, no one should doubt that the government cannot. It's a clear violation of the First Amendment free speech clause. And so John asked me if I'd been censored, and I gave an example of the first interview I gave after I filed my lawsuit, but right before I was fired, was with a woman named Allison Morrow on her podcast. And that was censored on YouTube. Her YouTube channel was suspended. And then she was
deplatforming. There was deplatforming.
Yeah, deplatforming. I was fired, and then she was told, if you don't take down that interview with Dr. Kheriaty off the other platforms where it's still posted, that we, the state of Washington Department of Natural Resources, are also going to fire you. And to her credit, I guess she refused, and she also got fired. So within weeks, I was censored and fired, and the person who spoke to me and had the first conversation about this publicly was censored and fired for talking about the ethics of vaccine mandates, which was a topic that I had some expertise on. We weren't even discussing, by the way, safety and efficacy of the vaccines. We were just talking about the ethical and legal implications of forcing them on people who may not have wanted them. So anyway, John said, well, do you know any other credible doctors and scientists who have been censored. And so I mentioned Jay, who at the time was at Stanford. I mentioned Martin Kulldorff, who at the time was at Harvard. And they got on board the lawsuit. Two other private plaintiffs, a journalist named Jim Hoft and a health freedom advocate from Louisiana named Jill Hines, also became plaintiffs. So the two states, Missouri and Louisiana, and those five private plaintiffs filed Missouri v. Biden. We went to the Supreme Court 2 years ago for an aspect of the case called the preliminary injunction. The court sort of punted on the preliminary injunction on a technicality. People mistakenly at that time assumed that the case was over and we had lost at the Supreme Court, which is not true, actually. The Supreme Court sent the case back down to the district court to move to the trial phase. And then just a couple of weeks ago, we were able to reach a settlement with the government where in the settlement agreement, which was endorsed by the court as a legally binding precedent in federal court, the government conceded that it had done essentially what we had alleged, that it had pressured social media companies, that it was not supposed to do this anymore. And so the court laid down very clear criteria in that with that consent decree, that part of the settlement agreement that is now public, basically articulating what the government can and cannot do in the age of social media. This is an important case because it was the first major censorship case of the digital age. So previous cases where the government violated people's free speech rights was usually a one-off event. A government official would call a newspaper or a magazine or a book publisher and say, strike this story or strike these few pages from this book that we don't like. And that's bad. That's clearly a violation of the author's or the editor's constitutional rights. But it was a one-time event. Whereas what happened with the rise of social media is the government had a censorship apparatus that was flagging content 24/7 and pushing basically through a complex ticketing system, pushing this information to social media companies with threats behind it. If you don't throttle these accounts, if you don't take down these posts, we're basically going to punish you. And they had all kinds of ways of doing that, which we don't have time to get into. But they would also pressure the social media companies to change their own terms of service and to change their own algorithms to censor. And this is how you ended up with tens of thousands of people being censored literally hundreds of thousands of times, which is why the district court judge in our case, when he issued the original preliminary injunction, said, if what plaintiffs allege is true, and the final outcome of the case suggests it was true, this is the worst free speech violation in United States history. Because the scope and the reach of the censorship with these new digital technologies was so vast. That wasn't one of the plaintiffs making that, grandiose claim. That wasn't one of our lawyers kind of making this rhetorically exaggerated claim. That was a federal judge saying worst free speech violation in the United States history. So this is a very powerful apparatus that the government had at its disposal that our case and the Twitter files, journalistic reporting, I don't think we've dismantled this entirely, but we've at least put a dent in this machinery. We brought it to the attention of the American public. It became an issue in the presidential election. We got an executive order on day one with the new administration vowing to dismantle this censorship machinery. And then after our settlement, the Washington Post ran a nice editorial saying that actually this is a good outcome and this is important. And they expressed concern about the new administration not having its hands on this censorship machinery, which I was pleased to see. Even though the case was called Missouri v. Biden, the plaintiffs the five plaintiffs, basically we ran the gamut of the political spectrum from left, right to independent. And for us, it was never a partisan issue. It was always a constitutional issue. We didn't want President Biden. We also don't want President Trump or any future president, liberal or conservative, Republican or Democrat, to be able to exercise that kind of power to try to control the flow of information online. So yeah, that's the short version of the Missouri v. Biden story. And it was, I think it was an important win for for health freedom. I was involved in another case here in California involving health freedom as well. California
There was that
published.
proposed legislation in California as well. Is that what
Yeah,
you're
that's
referring
right.
to?
Assembly Bill 2098, which is an attempt to basically put a gag order on physicians. And the
About
law said,
misinformation.
correct. The law said any physician who contradicts what the law called the current scientific consensus on COVID could be disciplined by the medical board, including having your license revoked. Well, of course, current scientific consensus is not a well-defined legal term. Standard of care over the years has become a more well-defined legal term, but especially on a rapidly evolving set of problems like a novel coronavirus, right? What constitutes the scientific consensus would not be clear to a practicing physician, and which basically cowed physicians into submission. I'm only going to sort of read a script from the California Department of Public Health just to make sure that I'm safe. And
It wasn't even about treatment. It wasn't like, maybe substandard treatment, like a person who decides to treat COVID with, homeopathy or something, where maybe they think that's not the standard of care. It was about merely enunciating a viewpoint that was counter the mainstream narrative.
That's right. You can't even have a conversation. Forget treatment recommendations. You can't, a physician can't speak his mind based on his own best assessment of the current scientific literature, of the evolving information that's emerging on COVID. So we filed a case called Hogue v. Newsom. Tracy Beth Hogue was one of the plaintiffs in that case, along with myself and 3 other physicians in California. We successfully got a preliminary injunction. It became clear that the court was going to rule in our favor in the final ruling. And so the legislature quietly repealed the law after the injunction went into effect. So we were able to beat that back here in California as well. So we've had a couple of key victories related to both free speech, but particularly free speech in the context of medical freedom. Because if you can't speak your mind, you're essentially living in a totalitarian system, right? That's the first thing that every totalitarian society does, is they forbid the asking of inconvenient questions. The prohibition of questions is the starting point, not concentration camps or mass surveillance or secret police. All that apparatus grows up, to enforce the regime's directives. But the starting point is always, you're not allowed to raise your hand and say, I don't know if these masks are doing anyone any good, and maybe they're actually harming people. Or should we really be forcing the injections on people? What about allowing them to make their own informed decision? No, you're not allowed to raise your hand and ask questions and challenge the regime. The totalitarian leaders don't sit down and have a rational debate with you. When you do that, they merely exclude you from polite society. They attempt to shut you up. And that's why it's so important whenever we see the rise of new mechanisms of censorship, it's so important, not just for health freedom, but, for civil liberties in general, to oppose that, because that's going to lead us in directions and toward a society that I think very few people want to live in.
Okay, folks, at this point, let's pause and allow one of our sponsors an opportunity to share an important message with you. So here goes. Listen up. Ever walk into a room and forget why you're there? Lose your train of thought mid-sentence? Feel like your brain is running on fumes by 2 p.m? Try Kyolic Specialty Series Smart Mushrooms Plus. This isn't caffeine. It's not some jittery stimulant that crashes you an hour later. This is a clean, science-backed formula built around certified organic lion's mane mushrooms, clinically shown to support the nerve growth factor that actually helps your brain maintain and organize neurons. We're talking real foundational support for focus and mental clarity, and it doesn't stop there. It's combined with Kyolic Aged Garlic Extract, aged up to 20 months on organic California farms, plus Aronia Berry Extract, selenium, and vitamin B12 for long-term brain health and executive function. 2 capsules with a meal, once a day, vegan, non-GMO, no gluten, no dairy, no artificial anything. Kyolic Smart Mushrooms Plus from Wakanaga. Learn more about this and the entire Kyolic Mushrooms Plus line at kyolic.com. That's KYOLIC.com. Look for Kyolic at natural health stores nationwide and online. Thanks for listening, and thanks for supporting our sponsors. And now back to today's guest, Dr. Aaron Kheriaty, author of Making the Cut. So, the question is, what you are a medical ethicist. So
Right.
what does a medical ethicist actually do? Because a medical ethicist doesn't actually, go up to patients and say, I'm going to teach you ethics. You
Right.
actually make crucial decisions about new emerging medical therapies, about things like assisted suicide, or what can be called euthanasia. You make decisions about priorities for organ transplantation. So tell us a little bit about how your views on this push back a little bit on kind of the mainstream trends
Sure.
that are overtaking medicine.
Well, sadly, I think mainstream medical ethics, or what's sometimes called bioethics, ethics related to both medicine and biomedical research, largely abandoned its post during COVID and became sort of spokespersons for the regime that I describe in my book, The New Abnormal, which is a regime of top-down authoritarian control that had very little to do with public health and had more to do with controlling entire populations for reasons that I describe in that book. What do medical ethicists do? Well, we do a number of things. Some of us write more academic papers on more theoretical issues. My own role at the university involved teaching the required ethics course to the medical students. That was important for me in the decision I make to challenge the vaccine mandate as well, because in lecture 2 of that course, I talk about the principle of informed consent. I talk about the Nuremberg Code and the Helsinki Declaration of the World Medical Association. The central principle of both of those landmarks of 20th century bioethics.
Even going back to the Hippocratic Oath, which is a central tenet. 2,000
years old. Yeah. So
do no harm.
So I just couldn't imagine myself standing up in front of the students in a couple of months when I taught the required ethics course and talking about informed consent when I had allowed this policy to go unchallenged that so egregiously violated that principle. And, lecture 5 or 6, when I talk about moral courage and doing the right thing under pressure, even though, you're at the bottom of the hospital hierarchy and it's scary, but, if you see someone being harmed, you have to step out and say something and do something to try to stop it. I felt I just wouldn't be credible if I hadn't actually taken steps to try to change that policy. I also chaired the ethics committee at the hospital, and we did consultations on actual patients. I did the same thing. I was ethics committee chair at the California Department of State Hospitals, the state psychiatric hospital system, for several years. So those are cases where there's a difficult ethical or legal question that the treatment team or the patient or their family is wrestling with, and they want some guidance on
whether to take a person off a respirator, or, instances like that.
Yeah, exactly. Difficult end of life decisions, real world decisions that have, real world, sometimes life and death consequences for patients. And so I had spent, many years doing that. And in that context, developed my own position on some of the kind of lightning rod, hot button ethical issues that are, still very much part of our debate today within society. So, in 2015, for example, the whole issue in California came up of whether we should legalize or permit doctor-assisted suicide. And my own view is that undermines the goals and aims of good medicine, which should always be aimed at health and healing and not at killing or deliberately taking human life. That doesn't mean we have to extend life at all costs. We can accept natural death when the disease has overmastered our ability to cure it.
We can sometimes withdraw very aggressive care in the case of a person with a very terminal prospect and offer hospice and supportive care, palliative care, that kind of thing.
Yeah, all of that is consistent with good medicine and the goals of medicine, but directly turning against the life of the patient, deliberately doing something with the exclusive intention of ending their life, I believe undermines the goals of good medicine. So when that was being debated in California around 2015, I became part of those debates. I testified against the bill, which unfortunately passed anyways, but testified at the California Senate Health Committee I did a debate with the founding dean of our law school at UCI, public debate on doctor-assisted suicide, which folks can still find on YouTube if they're interested in unpacking both sides of that issue. So I was involved in, teaching medical ethics and doing ethics consultations at the university, but also from time to time engaged in sort of these publicly important or publicly controversial questions at the intersection of, medicine and society.
And of course, there's the issue of organ transplantation. I think a central issue is, are we all potential organ donors? Because I think there's this controversy of whether there should be an opt-in or opt-out routinely on your driver's license. I think the current status in my state is that you have to opt in, but the proposal is that we should all, unless we decide to opt out, become potential organ donors. And you have a position on that.
I do. I talk about that in Making the Cut. I have a chapter that a large chunk of which, well, it's on surgery, but a large chunk of which is devoted to organ transplantation because it's such a fascinating aspect of the whole surgical enterprise. And I was fortunate to assist on some organ transplants during my training in medical school. And I argue there in the book, and in my position, is that we should have an opt-in system, that the default should not be that we're automatically organ donors unless we proactively do something to say that we're not, which is the case in some Western countries right now. Spain, a few years ago, went to a system of basically you have to proactively opt out. Otherwise, by default, you are an organ donor. And as I talk about in the book, I think there's several problems with that system. The automatic assumption that seems built into that system is that my organs fundamentally belong to society first.
Right.
Right. And I have to do something to claim them as my own, which strikes me as fundamentally wrong. My body isn't just something I have. It's a constitutive part of, it's literally who I am. Right. And so organ donation can be a beautiful thing when it's done right, when it's done under the right conditions, and when it's done in an ethically defensible way, right? But I argue in the book, we should always maintain the logic of the gift, right? That my liver is mine unless and until I freely give it to someone else or consent, at some unspecified time in the future, if I were to die, to give it to someone who may need that. And I think it's important for us to maintain that logic of the gift. I think in order to trust the organ transplant system, we have to have very strong assurances that the doctor's intentions are always going to be to treat me first.
Yeah.
And not to, let's say, compromise my care at the end of life in order to try to harvest my organs.
Yeah, this is an issue that was highlighted recently on an episode of The Pit, which you may have seen, where there was a whole kind of reflection on, how quickly can you declare a person brain dead because the incentive may be to harvest their organs,
The New York Times has reported on this recently. The Department of Health and Human Services initiated an investigation into what are called OPOs, organ procurement organizations, the groups that come in and broker these arrangements with patients who are dying and with family members, try to obtain consent for organ donation. And unfortunately, some of these organizations appear to be doing things right, but others appear to be fudging the lines sometimes. And there have been now some pretty disturbing cases reported in literature. Again, New York Times and others have reported on this, where it seems like the organ harvesting process itself was the cause of death rather than waiting for the person to die and then harvesting their organs, essentially killing them by harvesting their organs. So these cases threaten to undermine the trust of the public in the whole organ transplant enterprise. And that's an enterprise that can only function if people trust it and choose to participate in it. So I think it's really important for us to maintain the integrity of that system. We probably don't have time to get into it in today's conversation, but there are also controversies within bioethics on whether brain death itself, which is the criteria of death in all 50 states, is an adequate criteria for death. again, I think it would take us a little bit far afield to get into that issue, but I discussed that a little bit in the book, Making the Cut. And my own views on that have actually evolved over the years to the point where I am now more skeptical of brain death than I was when I began my training in medical school.
Interesting. Okay, we're going to divide our podcast into two parts. Our listeners know that we divide part one and part two. But in part two, I want to talk about a central issue of the book, Making the Cut, which is that medicine has somehow lost its heart. It's lost its humanity. How can we restore humanity to medicine? That is a central theme of the new book, Making the Cut, by today's guest, Dr. Aaron Kheriaty. More when we return. I'm Dr. Ronald Hoffman, and this is the Intelligent Medicine Podcast.